a priority area of focus for IANPHI, the network, and also for its membership. During this session, we're going to hear from 5 presenters who will share their experience either from their country or their organization. We're also going to hear about activities that the IANPHI Committee on Health Equity has done in the last year, and then round out with a presentation from Brazil about the activities of the IANPHI Latin America Network. So I'm going to jump right in because our first presenter needs to get to the airport. Our first presenter is from US CDC. It is Vic Kapil, who is the Chief Medical Officer and Associate Director for Science in the Center for Global Health at CDC. Vic.
Thank you very much, Shelley. My mic is good. Yes. Thank you so much. And it's a pleasure to be here. I've really enjoyed meeting many of you and speaking to you the last couple of days. And I really hope we have an opportunity to continue to engage on some very, very important issues that have been discussed at this meeting. I want to thank the organizers for inviting me as well to speak on global health equity. I'm going to make a few remarks about our work, the CDC's work on global health equity, which has really been a journey over the last year and a half. It isn't something that we did and we're done. It's very much a journey. And as we've heard the last couple of days, there are many, many things yet to be done in this arena. And many of the challenges we face in public health and global public health are related to some of these equity concerns and the social determinants that we're going to be talking about in this session. So CDC has actually published its global health equity strategy. We published this late in 22. It's readily available to you. You can snap the QR code if you want to, or you can download this freely available document. And it took us a good 18 months or so to develop this. And it took us a lot of time because we had to engage with a lot of organizations and a lot of people who were very important stakeholders for this type of work to be meaningful and to be impactful, including not only our programs in Atlanta, but also our 70 or so country and regional offices, our other centers within CDC and our other partners outside of CDC that we work with closely on global public health issues. The global health equity strategy is also aligned to CDC's core strategy around health equity in general. That also is available to you if you're so inclined and you want to see that. That core, the core is actually an acronym which stands for those 4 core components: cultivating health equity science, optimizing interventions, reinforcing partnerships, and enhancing capacity, and both internal and external capacity. We developed this strategy, the global health equity strategy, because we thought it was important to contextualize our CDC's health equity work for a global context and the country context, even in some cases within countries, depending on the nature of the country. So that's sort of the background of how we came to this. The vision is really fairly simple from our perspective. It's an expectation that everyone can attain the highest achievable level of health, and no one is disadvantaged from that potential because of socially, economically, demographically, or geographically defined circumstances. So it's about attaining the highest achievable level of health, which again, someone said earlier today about preaching to the choir. I think in this audience, I think everyone here appreciates this is primarily a public health audience. So you all appreciate the importance of a statement like this about achieving levels of health rather than focusing on other things, which sometimes get focused on. Not that they're also not important, but this is a health-focused approach. The strategy also takes a human rights-based approach because health, and again, as we all know, is a fundamental human right. It's recognized as a fundamental human right. It's interrelated and interdependent to other widely recognized rights, like the right to life, freedom from discrimination, and to be recognized as a person, as well as a basic standard of living for health and well-being. So this slide just shows you some of the important, in some cases, quite distant past descriptions of health being a fundamental right, going back into the 1940s. To further this approach, we identified 6 very key, for us, key guiding principles for implementation. First, and I don't think the pointers will work here, but if you sort of look to we sort of go around clockwise in a circle. First, we prioritize populations with the greatest need, or the most disadvantaged, or the most disproportionately affected. Second, we need to ensure that we prioritize engaging those affected populations and communities. So it shouldn't be about what we do in a community or what we do to a community, but it should be done together. It's engaging with those individuals and those communities. And third, partnership, collaborating with external partners, including non-traditional partners, those people in those communities who are trusted, who are local, on the ground, who know all of the ins and outs of the community. The fourth principle recognizes the importance of ethics and a knowledgeable staff, the respect for human rights, and the protection for people who participate in public health programs or participate in research activities, and so on. So that is the ethics sort of piece of this, very, very important. And implementing good and ethical public health practice, both scientifically as well as from a sort of a technical perspective. And last, ensuring that knowledgeable, qualified, and respected individuals are involved in planning and implementation of those interventions. All of those people, including people from the communities, considerations on their background, the perspective, need to be involved in those processes. In terms of implementation, what we decided to do and the way we decided to move this process forward was focused on being able to actually measure our performance and to hold ourselves accountable, really. So we have a strategy, but how do we know that we're making progress, or we're making progress in the direction that we want? So we established some, we think, relatively clear-cut and measurable goals. Those are within the circle here: strengthening CDC's capacity to advance health equity in science, programs, policy, and communications. Very important. Don't want to forget policy and communications. Building the evidence base to advance global health equity. And then finally, implementing standard health equity measures, measures that with real metrics. These are all built on those pillars which are along the bottom: science, interventions, partnership, and infrastructure, or an enabling environment, which I touched on earlier. Next couple of slides, I'll show you a few examples of some of the things that we have done to date. We have a lot of training activities going on. Some are very high level, some are quite deep dives, for example, with some of our country offices for multiple days, and again, with the country context in mind. This slide shows you an example, and this also is available to you if you'd like to take a grab of that screenshot or that QR code. This is a guiding principles for communication. So communication is very important. Words matter. Words can have different meanings and different connotations for people. So this is a document which provides some type of guidance on terms to avoid, for example, and terms that might be sensitive for certain segments of populations. Avoiding stigmatizing or dehumanizing language. There's just a couple of examples there, like hard to reach or addicts, or avoiding language which sometimes might have violent connotations to some people. We sometimes face this in the United States because in the US we like to use sports terms. So those are a couple of examples here, like I'm going to tackle a problem, or I'm going to tackle this issue, or I'm going to target a particular community for an intervention. So those types of terms even sometimes for some people have sometimes negative connotations. So this is just an example, the types of issues that are addressed in this document. Also science. We have taken, we've actually expended a fair amount of effort thinking about how to begin to investigate sort of the underlying contributors to health inequities, not just, and to build that evidence base, not just towards documenting the presence or the absence of inequity, but actually how do we move the needle forward towards eliminating those inequities, or making progress towards eliminating those inequities. So there are a lot of sort of systemic things we've had to do to address those types of issues. For example, looking at our systems for review of research activities, or clearance of research activities, or doing determinations. We have a process for research determinations, or non-research activities, or public health practice activities. So a lot of it has actually work that we've done in sort of trying to systematically address those kinds of issues, and to identify any gaps and to leverage any new evidence that we can develop. So I'll just wrap up with a couple of additional points. This is something we've just sort of kicked off thinking more intentionally about. And these are some of the key components for equity and global health relationships that we believe are really important going forward for us. And this is an internally looking activity where we're starting to think about how do we collaborate with our collaborating institutions, whether they are internal collaboration within the US government, within CDC, or our external collaborations with ministries of health, with partners, with philanthropies, with academic institutions, and how do we do that in equitable ways? The sustainability of our work. I think one of the themes from this meeting over the last couple of days has pretty clearly been, I heard it mentioned several times, about not doing sort of one-off things, parachuting, somebody mentioned parachute research or parachute public health programs. So thinking more systematically about sustainability, working with our partners and our countries where we work hand in hand as equal partners for long-term sustainability. The last couple of bullets, also very important, which are often not always on the forefront: financial considerations. How do we fund partners? How do we fund grantees? How do we word? What is the wording like in our notice of funding opportunities? How do we manage issues around financial accountability and so on? So there are lots of considerations that are financial in nature, which I think have been neglected and contribute to these some of these sort of the last bullet item, the power differentials. But it's not just about finances, it's also about personal relationships. And for ourselves, we have a lot of staff overseas, thousands of people working overseas, and some of them are directly hired American staff, and some of them are locally employed staff in the countries. And the relationships are different. Even again, our systems are different for those categories of employees. And those are things that we really want to think about and look at. And our new director, Dr. Kayla Lazarson, who some of you may know for the Global Health Center, is very committed to looking at those kinds of things. And also things like authorship and how all of those kinds of power differentials and dynamics between people are handled in equitable ways. And then finally, just a couple of key takeaways. It's definitely a journey. It's been very complex. It requires a lot of patience. And I think it's all about making our public health activities much more intentional, much more systematic, embedding health equity in everything that we do. And also, the bottom line for us, considering really who are the people who may not benefit from the public health services and programs that we're all about implementing, but sometimes those are the very people who don't benefit from the programs. I'll leave you with one thought. I was just in a meeting a couple of days ago. One of the speakers, it was an NIH meeting, and one of the speakers was Dr. Atul Gawande, who many of you probably know. He's the assistant administrator for the Global Health Bureau at USAID. And one of the things he was talking about is, we have, I don't know, I don't hold me to the numbers, but he said something like, we have 19,000 drugs that are approved by FDA. We have 4,000 surgical procedures, the highest technology. We have 1,000 public health interventions but yet we have all these public health challenges, things that we know how to do. And people have mentioned this repeatedly here in the last 2 days as well, whether it's measles or WASH or water or, whatever the issues are, we know how to manage those. We know how to take care of people with tuberculosis and people with HIV. And yet we constantly face these huge challenges in implementation. And I would submit to you, and what we want to be very intentional about is we want to take away the social determinants and the inequities as one of the contributing factors for those challenges. So thank you very much for your attention, and I'm very, very sorry that I can't stay in the afternoon, but I do have I have a flight to go to. So I really appreciate the opportunity, and
Great.
thank you.
Thanks so much, Becky. Appreciate it. And if any hard questions come in, we'll be sure to direct them at Vic and we can email them to him. So thank you for that, and really appreciate the emphasis on measurement, metrics, the resources that are available, but also really thinking about how what works is not yet reaching all people. I'm next going to turn to a presenter online, I believe. Dr. Jerry Ekmans is the Director of Social and Environmental Determinants for Health Equity with the Pan American Health Organization. Do we have Jerry on the line?
Yes, he's here. Can you hear me and see me?
Yes, we can hear you.
Okay, great, wonderful. Well, thank you so very much for having me here. I'm representing the Pan American Health Organization, which is a regional office of the World Health Organization, but it's also the oldest international public health agency from 1902, which actually was born in a context that is very much related to what we're talking about here, when countries were trying to build the canal in Panama and the railroads in the US, and they couldn't finish it because people were dying from yellow fever and all kinds of infectious diseases because of their conditions, because of their working conditions, their employment conditions, their living conditions. So that's when the Pan American Health Organization was created, and when WHO was created as part of the UN after the Second World War. We were taken in as the regional office also for WHO. So a little bit of an introduction. Within PAHO, as we call ourselves, we have a new director, a relatively new director. Some of you from the Americas, you will know it's Dr. Yarbas Barbosa. He's a Brazilian. He came in a little bit less than a year ago, and he created a new department. And this is exactly the one that was just mentioned, social and environmental determinants for health equity. And I think the name says a lot. This was created basically, understanding, learning from the past, understanding what happened with the COVID pandemic in the Americas. Why was this region for months the epicenter of the pandemic? And it has to do a lot with what we're talking about today, about the incredible inequities, the inequalities that we face in our region. When we were telling people stay home, work from home, if you have a workforce for 60, 70% informal economy, and people do not, get the means to stay home, obviously, your public health measures are not effective enough. And this is very much tying in to what has just been said by CDC, that you can have perfect public health measures, but if people cannot attain to them, if they cannot wash their hands because they simply don't have water and soap, then you are not, effective in your response. So based on that, this new department was created. Our region is, the Americas is probably the most inequitable in the world, within countries particularly, but also between countries. We have the richest country in the world, US, but we also have Haiti in our region, and everything in between. So we're working very much on trying to recover what was lost because of COVID. And of course, understanding that the setback from COVID is not in isolation. We already, if you look, for example, at the Sustainable Development Goals, we were already in a bad spot before the pandemic. We were already not attaining the goals. So of course, the pandemic only made that worse. Now, what are we doing about all that? So there, of course, we have mandates that have to do with, regional policies and strategies. For example, we developed a strategy that was adopted by all the ministers of health in the Americas in 2022 on advancing on the SDGs with equity through action on social determinants of health, to intersectoral action and to community participation. This is very much our guiding policy at the moment. For example, this year we are developing a policy on climate change and health equity, which is also very important. I think the climate change agenda really needs to, and climate change and health agenda needs to take a much stronger focus on health equity, because again, the ones who contribute less are affected most. And this is not only in terms of small countries, large countries, but also if you look at who are the most, the people in situation of vulnerability related to climate change, it's always going to be the poor, the ones left behind, the one in social distress. So these are just a couple of examples. So we started in-house. We looked at, okay, how do we make sure in WHO and in WHO that the policies we are carrying out and we are implementing, and our programs and that we're working on with our member states, with our countries, do have that equity focus. And again, it comes back to, who are we reaching? Two of the big initiatives that we have at the moment, organization-wide and region-wide, is the elimination of neglected diseases. It was just mentioned in the Americas, we have 30 diseases and conditions that are on the agenda to be eliminated. And we do that with a social determinants of health focus. So we look at each of those conditions, at each of those diseases, to see who are we not reaching, what has happened, and why, and what do we need to do, on those conditions that have been barriers to access to treatment, but particularly to living the healthy life that we need. So you cannot think about eliminating trachoma without water and sanitation. And so there's 30 examples that we can give, but this is really important. So this is one element where we are working very closely in changing our own programming and making sure that when we work with the countries, that this is really being looked at those social conditions. Then the other STAR program, the other organization-wide program is about addressing NCDs, much more non-communicable diseases, much more effectively, to again incorporating an equity and a social determinants of health focus into the work of the NCDs. I think, this is one of the clearest examples also how, if we talk about, preventing hypertension or treating hypertension, diabetes, etc., people are simply not going to a clinic or to a health center, particularly people who need their time to work and to make their money and their income to measure their blood pressure. And so we have to understand and think, what do we need to do differently? Well, how do these programs need to look in order, to reach people where and they can go and, so that we take away those barriers, those that are socially and economically, etc., determined. So we're talking very much about populations in the situation of vulnerability. This is very important for us because I think too long when we talk about vulnerable populations, we talk about like the biologics, we talk about men and women, we talk about race, we could talk about ethnicity, but we don't look beyond that. What is below that? What are those conditions that make that people have been vulnerabilized, are in those situations of vulnerability, and we need to understand how do we address those situations. We have also, we work a lot between countries. We have several networks that we use to move this agenda forward. For example, there is a network, and Felix was with us. It was launched last year on intersectorial action and community participation or social participation. Without those two key elements, we are not going to achieve our agendas. I think CDC also made it quite clear. We also have networks, for example, of populations in situation of vulnerability, where the civil society organizations are part of the discussion, and it's not us deciding what is needed. And this comes very strongly from the COVID response, where we identified groups, for example, unions of women who work in household, several domestic workers, with very often migrants, almost no rights. And so we work with them to see how do we need to do our policies differently. These are just some examples. We also have a very strong focus on local governments, where things happen and where things are needed is really in the communities, in the villages, in the cities. And so we have a strong network of mayors and local government officials and communities, of course, that look at how to integrate those aspects at local level. There was some mentioning around measuring, not just measuring deaths and disease and the gaps between them, but measuring and understanding the social determinants of health, the outcomes and the results of other sectors. The work of other sectors is extremely important, and we are starting to work on that, and we're developing a model that I think can be very useful, not only in the region, but also in other countries. Of course, our region is extremely, as I already mentioned, the inequities also have to do with the history. Our indigenous populations, our Afro-descendant populations, things like colonialism, racism, etc., extremely related to the inequities. But again, as I mentioned, it has to do with those social conditions that need to be changed. Now, last few points. I'm currently in Brazil, and yesterday, President Lula launched a program on eliminating tuberculosis and other socially determined diseases. Now, for some of us, this doesn't go far enough because we know that health and all diseases are socially determined. But I think just putting this on the agenda and have our infectious disease people forced to think about, if you keep doing what you're doing for years with your dots and you're not progressing, that something else needs to be done. And I think this is what's really, really powerful, that you see that the different sectors come together. In this case, they created an intersectoral mechanism with 10 ministries that are going to work together on this. This is extremely powerful. Has to do also with Bolsa Familia, with social with cash transfers, etc., the whole social protection area, but also employment, education, environment, we all know it. So Tedros, no, the Director General of WHO was there, our regional director was there. They are a very important event, and I think showing that things can be done and that we have to move our social determinants of health and equity language into action. You know, I think too long we have been, you know, a little bit esoteric about the social determinants, and everybody knows it's important and equity is important, but how do we do this? And I think those concrete things, like we're also working in Chile, in Colombia with the health sector reforms, not easy. There's always obstacles. There's always, you know, difficulties, political, etc. But these are moments where you need to really restructure your programs, your health systems, your health services. So, well, I think there is a lot more to say, but just want to thank you for taking this topic, health equity relating to health systems, to health programs, etc., and putting it on this agenda. I think for us, for PAHO, for WHO, this is extremely important, and we are here to work with you as your partners. So thank you very much.
Thank you so much. Appreciate those comments, and especially finishing with really that call to action. So we have the data, now what do we do? And I think these next two presentations will really speak to that. Our next speaker is Dr. Sofia Vegas, Deputy General Director with INS in Mozambique, who will describe their National Health Observatory and how they've taken their data to action.
Thank you so much, Shelley. So I will bring the example of INS National Health Observatory. Can you move to the next slide, please? So we chose this analogy to start our presentation. So if we imagine that this bug is health promotion and disease control, and the O's are the social determinants of health, it doesn't matter how much effort we do, the water will always leak. And that we should urgently close those walls and start investing in social determinants of health gradually, so that our efforts can have impact. And at some point we have a bucket with no walls. Next slide. Oh, okay. So what is our National Health Observatory? So our National Health Observatory was created in 2015 as a virtual national center for systematic and permanent observation of health and well-being of the Mozambican population. And the mission is to accelerate the generation of evidence on health determinants in the country. It is basically a platform that uses secondary data from different sources for data triangulation. And here you have a variety of data sources. So it comes from burden of disease, climate and environment, demographics, socio-anthropological, and economic. So I will talk a little bit about the law and the governance of our National Health Observatory. So it was created by a ministerial decree in 2015. Its implementation plan was approved in 2016, and we started the activities 1 year later. So the governance of the National Health Observatory is basically with an advisory committee that is co-shared by the Director General of INS and also the National Director of Public Health. And also includes the government, so other ministries, and also the National Institute of Statistics, partners, and also members of the civil society. So the recently approved Public Health Act in Mozambique establishes the National Commission on Social Determinants of Health. And it is basically a technical, scientific consultancy and advisory body in public health matters, and the scientific secretariat that was nominated is the National Health Observatory. Sorry. About the structure and operation. So the National Health Observatory works through these 7 different platforms that includes HIV, maternal and child health and nutrition, climate, environment and health, mortality, antimicrobial resistance, health systems, and scenario analysis and epidemic control measures. And these platforms, they work with multi-sectorial technical working groups that includes government institutions, academic institutions, research institutions, and members of the civil society. And as I mentioned, the technical secretariat is INS. So routine health data, surveillance data, data from surveys and databases from surveys, data from other sectors has vital statistics, socio-determinants, environmental data, climate, financial data, is used by the National Health Observatory for health situation analysis and modeling analysis. And the products of those analyses are then transformed into analytical products that are listed here. It can be bulletins, reports, policy briefs that are used to inform decision-making. It's hard to move. So I'll bring here some examples of the achievements of our National Health Observatory. This is an example from the platform of mortality, and it basically uses mortality data and compares with social determinants in different age groups and in the 11 provinces of Mozambique. So here, each of these small balls is one of the provinces of Mozambique. And here we are comparing with the illiteracy rate on your left, with the income per capita on your right, on the bottom, use of health services and access to health services. And this is compared with the mortality rate. And here you can see on top, you cannot see, but each of the provinces, they have each of the balls, the small balls, they have the initials for each province. And in the top, we have the province of Cabo Delgado in the north of Mozambique that has been affected by terrorism. Another example that we are bringing here, it's the function that the National Health Observatory has in raising awareness in health inequities. And here we are bringing some examples of events that were hosted by us. One in 2017, that was a public debate on climate change and health inequities. This event had the participation of the Ministry of Health and the Ministry of Environment. And last year, we also hosted an international conference on impacts of climate change and health inequities. This also took place in Maputo, and with the presence of around 300 participants. So each year we have a thematic report, and we plan for this year a thematic report on the impacts of population growth and health inequities in Mozambique. So at present, we have a population of around 33 million inhabitants, and it is expecting to double in 26 years. So in 2050, we are going to be 66 million. So this is a pertinent area to tackle and to give more emphasis on. Okay, so this is my last slide. So United for Equitable Health and Wellbeing in Mozambique is the slogan of our National Health Observatory. You have the website there where you can get more information. And I also learned a new word yesterday in Kenya, Rwanda. That it's murakoze, that it's thank you in the local languages here. Kanimambo in one of the local languages in Mozambique. Obrigado in Portuguese, and thank you very much for your attention.
Thank you so much, Sophia, and really helpful to see how the data and the analysis is really informing how Mozambique is addressing inequities. We'll now turn to Colombia and Dr. Carlos Castaneda, who is the director of the National Health Observatory in Colombia at the National Institute of Health, INS. Carlos?
Hi, thank you, Shelly. Are you seeing my screen?
Yes, please.
Okay, perfect. Okay, this is a particular view of the Colombian, of the National Health Institute in Colombia that has since the 2013, the National Health Observatory, that is a instance to follow the health situation in our country, but the central axis of the analysis and the recommendation that we provide to government and other decision makers are the analysis of the health equity. Then we are providing some evidence and some discussion about how to include the health equity in our analysis and our recommendation. It's central to understand that Colombia is a South American country with more than 50 million people, that it's one of the countries with the worst inequality in income, but also a big evidence of social inequalities in our population. Also, it's important that Colombia was a armed conflict of history of 60 years or more, that recently signed a peace agreement with the biggest guerrilla, but other armed groups are involved in the conflict. In a couple years ago, we present some evidence about health inequalities in our country from the analysis of the National Health Observatory in different levels. But we are presented today what is the initiative and learnings of equity analysis from the public health data since the Colombian experience. Additional, a very few health new evidence about health inequalities, especially in the scenario of the COVID pandemics, and actual recent discussion about the health system reform that Pajo mentioned a few minutes ago. And also final thoughts about the impact on decision making and next steps in the labor of the National Health Observatory. We have evidence of disparity across different stratifiers in our country. We have evidence of socioeconomic inequalities, gender, ethnicity, social class, that was a particular analysis that we constructed, armed conflict, territory, and during the COVID pandemic, or annual reports and different communicative material give the information and the recommendation to decision maker, to the parliament, to the health minister and other ministers using an intersectorial view. Our analysis include, for example, burden of disease for different outcome results, qualitative and mixed methods, because for us it's very, very important to understand the context where the inequalities arise, and equity in health analysis as main approaches to generate results and recommendations. In these 11 years, we strengthened the capacity in data analysis to generate reports, annual reports, 2 bulletins at the year, and articles in different journals, national and international, infographics, and other multimedia to try to involve, to many publics, many profiles in the population that can generate a new public policy or pressure to generate a new intervention in the government. Our analysis also include, for example, the construction of indexes, different indexes to territorial level, because we have more than 1,000 municipalities. And in many cases, in spite that we use mainly official information available in the official database, we also can perform some case studies, especially with a qualitative perspective, with a team that is a social researchers, confirmed by social researchers, anthropologists, sociologists, politologists, that also give a complete framework of the context of the situation in the particular regions of our country. We use all available data to implement or inequalities analysis, for example, vital statics, populational surveys, data from surveillance, that is other direction here in the Colombian National Health Institute, and we collect additional information for the most vulnerable people. The qualitative analysis to understand the context, it's crucial for us. We try to approximate to people perception, how they are suffering, to understand and to communicate the important to take action about the health problems and the inequality that is present in our context. A recent strategy to implement it to reach more easy to decision makers is the policy brief, the policy brief strategy, but we also use other channels to guarantee the acknowledged appropriation and use, because we know that the information and the evidence in many cases are available, but didn't know reach the people that can take an action. For example, here is the more recent analysis about inequalities. In COVID pandemics, we use transmission and severity index at municipal level, and show how the more deprived jurisdiction have the worst impact in severity, and this severity impact is related with less healthcare access, higher ethnicity population, or overcoming houses. Also, other health results were evaluated during the pandemics. The maternal mortality, that is a tracer indicator for health access, quality, and also the presence of inequality, showed that the rate was bigger during the pandemics, but the more the worst part of this finding, that was the poorest woman was the higher rates and higher increase in their mortality rates during pandemic, and we approach and publish that information. In the scenario of the health reform in Colombia, that is one of the many social reforms that the new government that was almost 2 years in our country. In that case, we did an analysis about avoidable mortality for any politic or by any policy, or exclusively attributable to health system. And we detect that more than the half of deaths in Colombia are avoidable due to any policy, but in the subgroup of access to health system, almost 20% of the deaths are will be avoidable by the access to health system. It's a very important message. And in terms of inequality, we identify that the poorest municipality has the percentage of the total deaths that are more avoidable due to a health system. And in similar way, we related the mortality, the avoidable mortality due to a health system related with the access with the health system, and also show some inequalities. And for health class, because we also could do the analysis grouping the people according with social class. The final message in the discussion, sorry, are we, for example, we had experience and learnings about how to inform decision makers with this information. In the COVID pandemic, most of the information, most of the decision was taken based in models created at the National Health Observatory, but also discussion about health inequality was informed by or analysis. In the case of environmental burden of environmental disease, that is a very strategic team here in Colombia. We informed the decision, the policy about the environmental health, about from our analysis about estimation of how many deaths are related to environmental factors, risk factors, and we are informing right now the information, the discussion about the health system and reform that is coursing right now in our parliament. The next steps is include the One Health perspective to achieve a real intersectoral impact in the decision, some special topics that are or many interests, and in the next year is the climate change, the antimicrobial resistance, migration, and the use of data science. And we are working right now in propose a new strategic public health national plan that include the inequalities at the different discussions around the global scale that inform the next years in public health in Colombia. Thank you so much.
Thank you so much, Carlos. Very much appreciated, and fascinating to see the data on avoidable mortality. I hope the policymakers were taking note on that. We'll come to our final speaker in this part of the panel. I don't think Dr. Raju Tajuddin needs any introduction. You're going to win the medal for most presentations during this meeting, but lead for NPHIs and workforce at Africa CDC. Taj.
All right, no, thank you so much, Shirley. I think if it's a Cup of Nation, I will win the trophy for the most appearance. So having said that, let me start on an acknowledgement note. I think as a resident doctor in pediatrics and later public health, I read a lot about Sir Michael Marmot, because he did a lot of work as far as social determinants of health is concerned, you know, and I think going forward, that's a very good reference for, as far as health equity is concerned. Now, having said that, I would like to frame my discussion around the COVID-19 pandemic and what we did as Africa CDC to address some of the inequality that's always been there, but got laid bare because of the COVID-19 pandemic. So the first case of COVID-19 was recorded on the continent in Cairo, Egypt, 14 February 2020. Realizing that this is going to be a marathon, not a sprint, so we quickly, as Africa CDC, decided to leverage the political platform, because the Africa CDC, as you all know, is a political institution. It's a technical institution within an intergovernmental political organization. So within the first week, we convey the meeting of all the all the ministers of health, 55 member states. And at that meeting, the strategy and the task force to drive that strategy was approved. And what were some of the challenges that were, highlighted at that particular meeting? First was the fact that most of our member states have what we call, or what would best describe as weak and fragile health system. We knew that access to medical supply was going to be an issue because we saw what happened with some of the vaccines. We saw what happened with the HIV/AIDS drug, the antiretroviral. We also knew that health workforce capacity was going to be an issue, lab capacity, collaboration, continuity of essential health services by our primary health care, data sharing, and of course, information management. So the first thing we did after the whole, the political leverage was to come up with different technical working groups in collaboration with our member states, because we believe that this is one of the things that will allow a member state to be able to respond, in a very, efficient and effective way to the COVID-19 pandemic, irrespective of availability of resources. Because in the course of trying to understand what is available, there's one member state which I'm not going to mention the name. We were trying to map to understand the critical key equipment, and in this particular country, they had more vice presidents than mechanical ventilators. So it tells you, the degree of the inequality and the problem at hand. So fast forward, diagnostics. When the COVID-19 pandemic first hit the continent, there were only 2 labs that could diagnose the SARS-CoV-2, South Africa and Senegal. And what did you do as Africa CDC? We quickly mobilized the other member states, organized 2 trainings, one in Senegal, the other in South Africa, so as to beef up the capacity. This was followed by securing the diagnostics that will allow those member states, to be able to diagnose the SARS-CoV-2. Secondly, the member state that didn't have adequate workforce, we had to leverage the African Union Peace and Security Council, because don't forget there was a lot of lockdowns, so we leveraged that asset at their disposal to use the military equipment or the military, flight to move workforce from the Central African region to some of the French-speaking West Africa. Number 3, the issue of access to diagnostics didn't just stop there. There was, we had in place the global supply system that was put up in Geneva. But what was going to be allocated to the continent of 1.4 billion people is not even enough just for one member state. So using the political platform, we quickly reach out to some of these manufacturers and let them know that Africa CDC or African Union, as a continent, is not looking for goodwill. Neither are we looking for charity. But please give us what is it that is our own share at the most appropriate price. So with that, we're able to secure some supply of diagnostics. And in the same vein, we launched the African Medical Supply Platform, so that beyond diagnostics, other life-saving equipment, we're able to secure that through that platform. And by so doing, most of our members actually had access, irrespective of their ability to pay. Fast forward, the COVID-19 vaccine was approved. Again, access to that was also a very big issue. So it's like passing through the hole of a needle. And our head of state and government came in at that time using the African Union platform to launch what we call the African Vaccine Acquisition Tax Team. From there, a trust was, formed. And with that particular trust, we're able to mobilize as a continent $2 billion US, so that at the end of the day, most of our member states were able to secure these vaccines. Again, that also brought up some other issues. You have secured the vaccine. What about getting the vaccines to the last mile, getting it, moving it from the pot to the arms of people? The capacity were not there. So through partnership, we're able to secure resources, 1.5 billion, that allow us to procure more vaccines, but much more importantly, to be able to deliver the vaccines to the people who need the vaccine the most. And it was in that same vein, we said never again. As a continent of 1.4 billion people, you only have capacity to produce 1% of what you need as an essential vaccine. And that's when our head of state and government launched the Partnership for Africa Vaccine Manufacturing, which today has supported a couple of member states to begin that journey of trying to manufacture vaccines locally. And Africa CDC continue to provide a lot of support and capacity for most of these member states. In the aspect of clinical trial, we also launched the consortium for COVID-19 clinical trial, and that has now metamorphosed into part of the pillars within the framework for action within the Partnership for Vaccine Manufacturing to drive the R&D component of our local manufacturing capacity. Colleagues, ladies and gentlemen, I think there's a lot to learn from the COVID-19 pandemic, and that's the reason why I frame my discussion around that. If you go back over that 3 years, I think one of the commonly used word is equity, and whether we like it or not, I think we as Africans were at the receiving end of that particular inequitable access to all those life-saving equipment. So all this put together, when our head of state met in 2022, they issued a call to action that the arrangement has been in place since 75, 78 years ago. That's when some of the UN agencies came on board, can no longer work for Africa. And so that's when the whole idea of a new public health order begin to gather momentum, and this new public health order, again, for point of emphasis, is really calling for us to strengthen our public health institutions, to begin to expand our local manufacturing capacity for those health security commodities, vaccines, diagnostics, therapeutics, and other medical products. The new public order also emphasized the need to expand or to begin to strengthen the development of our own health workforce, so that primarily when there is any outbreak, there should be a national level capacity that should be able to respond before we begin to call for, assistance. Number 4, domestic resource mobilization. That is also critical. And the head of state, in their own wisdom, did appoint President Paul Kagame to champion that, so that our air security does not continue to rely on goodwill or charitable approach. In fact, there's one quote from President Paul Kagame that you cannot guarantee your air security through goodwill. So you need to have a strategic approach to that, and a lot of effort is ongoing, to make sure that we're able to mobilize domestic resources to really, drive the health security agenda of the continent. Last but not the least, as part of the new public health order, is the issue of respected action-oriented partnerships. A partnership that respects the sovereignty of our member state, partnership that take the priority of our member state as the central point of whatever support that is coming to our member state. So on a final note, the issue of equity is there, it's systemic, and we need all hands to be on deck to address that. Africa CDC, African Union, we have all called for a new public health order, but it continue to remain a slogan without the support of each and every one. So I think this is a very big opportunity, since this issue is coming up, for us to know that it's a big issue, and we have to find everything humanly possible to address the issue. Thank you.
Great. Thanks so much, Taj. Appreciate that. And now that we have heard from 3 countries and 3 regional organizations, we're going to open it up for questions before we move to updates from the committee and network. So if you have questions for our panel, I think we can get microphones around. Or if anyone would like to share examples from their country, we're welcome to hear that too. I think we're in the post-lunch lull. Yes. There's 2 up front.
Elegant presentation from Mozambique on the Health Observatory. It is what I call strategic information for public health action, and also an elegant presentation from Colombia on mortality, avoidable mortality. A lot of health issues and inequities can be sorted out by public health and not medical care. So that's important. But the solution to inequities, which we achieved before, is primary health care. Mozambique, just after independence, the foundations, just like Zimbabwe, was on primary health care. Within 5 years, 7 years, we rapidly made equitable health care access to everybody. And that is also the greatest success of WHO under the leadership of Abdan Mahler in the 80s and 90s. That's why when you talk about universal health coverage, you can't do it without primary health care. So the quicker we move with primary health care, we'll address the inequities which we are recording all the time. So I suggest this important subcommittee becomes health equity and primary health care. Thank you.
Thank you. Right next to you. There's 2 more questions next. Yeah.
Thank you very much. My point of entry really has to do with equity, workforce development, and partnership, looking at Africa and of course the North. One of our major challenge is the fact that our best people are leaving for obvious reasons back home. And sometimes when we send them on training, they don't come back. They get absorbed. So how do we define equity in such a situation when we don't have enough, and yet the best are going? They can't come back. So if we need to talk about equity, then we need to bring something to the table. Now, these are the guys who can bring to the table, who can take the skill, bring the skill back, so that we also can come up with things that we can use to sit at the table and discuss with our colleagues. So this is one area I wanted to see your views about how this kind of challenge can be solved.
Thank you. Maybe we'll take one more question just behind him and then have the panel respond.
Yeah. First of all, thank you for very, very good and important input. I have a question for the strategy and the African CDC on creating local production of vaccines. I think we all left wounded by this whole vaccine struggle, and it's a low peak, not seen since like the HIV pandemic was at the peak, and we couldn't get medication for all patients. But then again, there's a challenge because I mean, you would like to secure local production, but you would also like to secure the best available technique. So how do you balance these things? You have like have you organized with big pharma companies? How are you going to get around that?
Great, thank you. So we have the comment about the importance of primary healthcare as a first step to improving public health, and then also how to tackle the problem of workers leaving, and the best skilled workers leaving country. And then this final question about vaccine production. So maybe Taj, I'll ask you to take that final question and then turn to the panel for these other 2 points.
All right. No, thank you for those questions. Let me start with Shiva on the PHC. I agree with you. If you look at the work of Sir Michael Mahmoud, it was also around the issue of primary health care. How do you address those social determinants of health to be able to guarantee universal health coverage? But the big question we need to ask ourselves sincerely, universal health coverage, is it attainable? Is it achievable? So I leave that for colleagues to continue to brainstorm. So, but there is no doubt about it. We need to invest in primary health care. And for Africa CDC is one of the areas that we've picked, we've decided to be looking into. We're looking at how do we support the primary health care workforce community health workers? How do we get them institutionalized? How do we get them regulated? How do we make sure that they work under supervision, you know, and how do we make sure that they are paid and not volunteer? We're also looking at the aspect of digitization, connectivity, solarization of our primary health care, you know, so that you only don't have a building, I call it primary health care. You need a functional primary health care. So I agree with you, but whether that universal coverage is attainable or not, I leave that discussion for another day. For Prof. Salako, the issue of our workforce, I'm looking at Kasum Diallo at the other side there. This one of the issue, or even in fact, the major issue at the last fifth Global Forum on Human Resources for Health. You know, so it was, I mean, a lot of discussion. How do we, because one, there's human rights to it as well, you know, because you cannot stop somebody from going, you know, you cannot enforce it. Even when you come back to the developing world now, we're beginning to see a situation whereby on one side, we're complaining that we do not have adequate workforce. On the other side, we have people who are trained and not employed. For instance, when I did Ask Job, I got placement in 5 different places. Today, to get anybody a slot to do Ask Job is a difficult task, at least in Nigeria. And I want to believe the same thing. Even in Ethiopia, I've seen that happening. You know, I saw a surgeon, well-trained, consultant, looking for technical officer job at the Africa CDC. What is happening? You know, so I think it's something that we need to bring all the relevant sectors together, you know, look at how best to approach this. Relevant sectors, education, health, finance, planning, labor, and all those, and what have you. And we also need to strategically engage where these people are going, you know. So what sort of mechanism should we put in place that will allow them to be able to support our systems? You know, I don't have the answer to that, but maybe Kasum will also weigh in at this point. But at the international level, a lot of brainstorming is ongoing, WHO, Africa CDC, ILO, to see how do we address some of these issues. On local manufacturing, so it's a space that is a bit complex, you know, but whether we like it or not, we cannot also continue to import vaccines for 1.4 billion people. It's not possible, you know? So we need to begin to find a way to produce these vaccines locally. You know, we need to find a way to begin to do capacity building, you know, and capability building. And this is one of the lowest hanging fruits where Africa City is making a lot of investment, trying to set up those regional centers for capacity and capability building with regards to vaccine manufacturing. Market shaping. You have produced your vaccine locally. Can you compete with those companies from China, from India, from Bangladesh? You know, so what sort of legal framework do we need to put in that space that will say, okay, Gavi, UNICEF, you are the largest, largest institution that procure vaccines for the low and middle income country. What percentage of your procurement should come from the low and middle income country? Because if you leave it open, surely those companies from the low will be outcompeted, especially in Africa, who are new in that space and do not have that financial muscle of places like Serum Institute of India, you know. So in that regard, we've put together a framework for action, you know, which is on our Africa CDC website. So please, let's try and look at that, because there are a lot of things that is moving in that space. But I can tell you that it's a complex space, you know, but we need to start that discussion. That 1% is a no-go area for head of state and government. We need to begin to produce locally. And by 2040, they want to make sure that 60% of what we need on the continent is produced locally. You know, most of the big farmers have been engaged. We know Rwanda has made significant progress. Morocco is making a lot of progress. South Africa is making progress, but 5 steps forward, 3 steps backward. But I mean, who get it right? Let me stop there. Over to you, Shirley.
Yes, let me turn to others on the panel, and then Kasum will come to you. Sophia, did you want to comment, or Jerry or Carlos?
I don't want to be repetitive about the the primary health care. We totally agree. I would also comment on the subsystem of community health care that it's being established now, and also bring the example of our mortality platform. One of the slides was an example of our mortality platform that uses data from the community that it's collected by community health workers. So we are already tracking data from the community, but I completely agree with what was said. Thank you.
Thanks, Sophia. Any comments from our colleagues who are online?
Yes, thank you. It's Gerry. Thank you for the comment on primary healthcare. I think it's absolutely crucial that we look at the role of the health sector and is to primary healthcare through public health if we really want to make in ways. At the same time, when we look at social determinants of health, I do think you also need interaction at other levels with other sectors. So, and of course, primary healthcare as originally intended, and as Mahler was mentioned, was about intersectorial action at local level, was about the participation of the community, etc. But I think really what we have learned is that most of our health, our well-being, and our health inequities or health equity is not created by our health system, but is created by policies of other sectors. And I think this is really important to keep that balance right, that within the health sector, of course, we need to work on public health, primary healthcare, but we also need that other capacity to engage with other sectors in a meaningful way so that their policies can contribute to health. Thank you.
Thank you. Carlos,
Okay,
any comment, or we can?
Yes, I also want to mention that the important, the potential use of the avoidable mortality is precisely that we can take into account that the inequalities, the health inequalities, is product not only for one. In one hand, for the social conditions that are required intervention beyond the health system, but also the health system has participation in reduce the inequalities, because a portion of the avoidable mortality is responsibility of the health system. Then we also to improve, to strengthen the health system, the primary health care perspective is very important to introduce the prevention and promotion of the health, and not only attend the disease, but also in the setting of Colombia, under discussion of the health reform, we also has to have in mind that the progression of this idea to improve the primary health care also have to take into account that the actual the present impact in health system, the high cost and chronic disease needs attention right now, and we do need to reduce the impact in health with specialized care. Thank you.
Thank you so much. And final comment, can we get a microphone to, yep.
Thank you. Thank you for the question. And I think, Raj, you covered it very well. Just two additions. One is that there is the code of practice for ethical recruitment of health and care workers. And this code has been around now for quite some time and has been the list of countries who are what we call the support and safeguard list. It's the list of countries for which WHO recommend to not actively recruit from them because of very low densities of health workers and UHC coverage index. So this list have been updated last year. So we have now 55 countries there, and then this is a recommendation. But there are some ways around it. What we are recommending, not to actively recruit from there, but we are also recommending bilateral agreements between the recruiters and then the senders. And that's something. So it's a win-win situation through which the recruiters will also invest in the health system, strengthening the health system and the health workforce of the countries of origin. And that we have excellent example of very successful bilateral agreements between African and European countries or between Asian and European countries. It's working well for some things. So this is something that we recommend. So any recruitment that is engaged in your country, make sure that it's formalized through a bilateral agreement between the government and governments, so that this is something that we need. The human rights dimension is there. So that's one of the key elements that I think we have to keep in mind. The other thing is that in reality, when we talk about this recruitment, when you look at it, it's a very complex issue. Because if you are hiring a doctor for low-income country, which was covering 10,000 people, this doctor will be covering 200 people in your country. So this 10,000 and 200, this is something that we have to keep in mind in the bilateral agreements things. But it's not a one-to-one thing because of this. The other thing is, this is something that is going to increase because our studies have shown that in high-income countries, in many of those countries, more than 1/3 of the health workers is age 55 plus. So these people will be retiring in the next 10 to 15 years. And the education system, there is no way they can replace all of this through those education systems because of numerous clauses and many other challenges. So it is important that this is also part of the overall discussion in public health because it is central to really the management of the workforce. All what we are talking about here, in reality, it's also linked to managing the workforce. We are talking about working conditions, career path for public health and care workers, and all those dimensions, lack of investment in education and jobs. We are talking about physical space. All of these have to come together as one. And it's important that we keep in mind in this discussion. Thank you very much.
Thank you so much. We're going to move on. We're running short on time and have two more presentations. I am going to present what we've done as the Committee on Health Equity for the last year. I'm presenting on behalf of Felix Rosenberg with Fiocruz, who is co-chair with myself for this committee and also members of the committee. We have slides. So we should, there we go. So this map, what you're seeing right now, represents the members in this committee on health equity. And I'm beginning with a call to action. We need you. As you can see, we have representation from all regions of the world, which was one goal in this first year of being a committee. But the representation from Africa and Asia is quite limited. We certainly welcome additional members. We want to make sure that what this committee is doing is really the voice of this membership, and having good representation is important for that. So thinking about what we did in 2023, our first success is that we launched. We actually became an official committee within IANPHI and began meeting at the beginning of the year. We really spent time hearing from experts, potential activities, brainstorming about the things that would be beneficial for the IANPHI membership. And in November, you may have seen that call for additional members to all IANPHI committees. And with that call, we actually doubled the number of countries that were represented. So that map that you just saw is an improvement. When we show the map next year, I'd like to show another improvement. So the committee really has defined three driving priorities. The first is a belief in health equity in all policies, that it really should be part of any conversation that is impacting health. And obviously that is outside of healthcare and public health, as we have just discussed. The second is really the importance of NPHI capacity to take action in addressing inequities. And this third driving priority is looking at the expertise in this room and across the membership of IANPHI, and really thinking about peer-to-peer exchange specific to health equity and addressing inequities. So stemming from the priorities, we've developed three objectives that are part of the draft work plan. The first is focused on the structure and composition of the committee itself, obviously representation from all the regions. Also thinking about how this committee connects to and relates to the other committees in IANPHI. and also engaging with the IANPHI's regional networks for both feedback and input as we move forward with activities. We would also like to generate knowledge and share what has been learned in the committee discussions. This could include collating various resources that already exist and making those easily accessible to the IANPHI membership. Certainly facilitating conversations and having webinars on particular topics, such as the role of NPHIs in responding to socioeconomic determinants of health, and also how NPHIs can advocate for equity in all policies. This would extend to resource development, such as case studies, policy analysis, or potentially a position paper. Our external partner engagement will identify key stakeholders in the fields of health equity, so government bodies, NGOs, community organizations, and also participating in relevant global and regional forum to highlight the work done and also the role of NPHIs in equity. I think. So next steps, we are currently finalizing feedback from the committee on the draft work plan. We will present that to the executive board. That needs approval by the executive board, and then actually begin implementing activities in 2024. So remember, we need you. We welcome your participation, and let me know if you're interested. I will now turn to Felix Rosenberg with Fiocruz in Brazil to report out on activities from the Latin America IANPHI network. Felix.
Thank you so much, Shirley. Good day, everybody. Because of time, I'm going to be very quick about the next, please, Paul. Next slide, please. So I'm very quickly going to talk about our Latin American Regional Network on Health Equity workshop we had in Petrópolis, Rio de Janeiro, Brazil, last August last year. The next, please. We had participants from Argentina, Brazil, Costa Rica, Chile, El Salvador, Mexico, Peru, and Venezuela. We had a bicontinental presence of the NPHI of Mozambique, which has presented their health observatory, CDC Atlanta, IANPHI in Emory, PAHO, and a representation from the Canadian Public Health Agency. And we prepared to organize working groups in order to put forward proposal to strengthen health equity at the global, the national, and the local levels. Next, please. At the global level, we focus on exactly what has been mentioned by Tash, among others, that the economic and technological dependence of the least developed countries is a priority in access to health products and supplies, medicines, vaccines, diagnostic reagents, as has been mentioned here. We propose activities mapping what the institutes in the region are doing, do a strategic analysis specifically of diagnostic kit production capacities for primary healthcare needs, comparative analysis of regulatory frameworks, and dissemination of training that is generation of knowledge and production capacity for strategic health inputs. The next one, at the national level, we have prioritized the unequal and unfair access to health services, particularly at primary, specialized, and complexity care, high complexity care levels. We proposed activities to define the role of the national public health institutes in research of inequities in health services, writing a reference framework, organize a network of focal points to conduct research on inequities in health services, carry out a research project on primary health care in each country, because we agree, as here was mentioned, this is a major asset. Carry out research on project on health services in border areas, mapping and evaluating existing observatories of health inequities, as has been presented here from Mozambique and Colombia, and promote a strategy, for the presentation of good practices of observatories. And the last one, the next one, please. At the local level, territorial level, we prioritize the fragile territories where the social and human rights to the city, as we mentioned, that is to say housing, sanitation, education, transport, sports, entertainment, etc. And in order to face this challenge, to share existing documentation on participative rapid diagnosis and participative cartography, a virtual meeting will be held to resolve doubts and solutions to the identified barriers. Methodology will be implemented in one community in selected countries to pilot its implementation, and then from there on, we will share experiences and write an article in order to try to scale up this methodology to other communities in other countries. So very quickly, this is what, as you can see, at our regional Latin American level, we have practically reproduced, in a sense, everything which has been spoken, has been said and prioritized today in this meeting. So thank you, Shelley, so much.
Great. Thanks so much, Felix. I know we're over. Well, is there one question? Any question before we close? Thank you. Over here.
Yeah, thank you to all the panelists in this important presentations. But just to follow up on a comment you made, Shelley, in that this subcommittee in relation to many of the other subcommittees, I couldn't help but notice in several of the presentations the mention of climate change and equity. And so I think there could be opportunities for cross collaboration of those two committees. So thank you.
Completely agree. That's at the top of our list. Yeah, no, I appreciate that. So thank you to all of our panelists. Felix, any closing remarks as co-chair of the committee?
So thank you, Shelley. What we have heard today is that there is actually no time left to demonstrate that social inequalities are responsible for health inequities. For over 20, 30, 40 years gap in life expectancy, for quality of life, well-being, and for human rights. Since John Snow in cholera 200 years ago through Latin American researchers in the 70s, Michael Marmot, as was mentioned here, among others, more recently, including the National Health Observatories, this has been largely demonstrated. It's time now for the health sector through the National Public Health Institutes to act with other sectors of government and social and community organizations to effectively change this reality by focusing the elimination of inequalities and social inequalities and health inequities. And this is exactly what we expect at this IANPHI Committee on Health Inequities. And we really wish that you will join us in this committee to face this enormous challenge, which is certainly the most important challenge in public health. So thank you very much, and my congratulations to IANPHI and to this wonderful discussion we had today. Thank you very much.
Thank you so much, Felix. And thank you to our panel.